Thank you very much. So I'm going to talk to you now about another area that is of active interest at Columbia, and that's the development of a complex higher risk in indicated patients, PCI. So here's a patient, 55-year-old male with hypertension, hyperlipidemia, 4 months of exertional angina and nuclear stress test, which is positive for ischemia in the inferior wall with a normal EF. And here's a 55-year-old male with hypertension, hyperlipidemia, 4 months of exertional angina, nuclear stress test positive for inferior wall ischemia with normal EF. Why are these patients treated so differently? Probably because of this. So courage has led to a paradigm shift. In 2007, William Bowden published in the New England Journal of Medicine that optimal medical therapy was equivalent to PCI and optimal medical therapy in terms of freedom from death and myocardial infarction. And this has had significant impact around the world. Certainly from the Massachusetts registry, you notice that the time from publication of Courage, there's a significant decline in elective PCI and elective CABG, whereas PCI for MI and elective are almost now stable. But there is fine print. 36,000 patients were assessed for Courage and only 3,000 met the eligibility criteria. 8,000 didn't meet inclusion criteria, 6,500 were excluded for logistic reasons, 18,500 had more than one exclusion criteria. And actually, if you look at the data carefully, this data from John Spertus shows that those patients in the optimal medical therapy arm, their freedom from angina drops significantly over time, and there's a significant crossover rate at this point. And if you actually look at the data, the confirmed study shows that compared to medical therapy, revascularization in 2-vessel and 3-vessel disease leads to a trend, but in some cases a significant reduction in all-cause mortality. So what's really happening with Courage in real life? Well, what's happening is the development of appropriate use criteria. This is present in the US. Who can you treat and who can you not treat? And what this has led to is a shift from patients with simple type A lesions, which can be treated, to the more complicated patient scenario where more and more patients are having 3-vessel disease, multi-vessel disease, and as you can see, the 5-year survival of those patients is significantly worsened. You can see here from the time Courage was published that NSTEMI with left main coronary artery and 3-vessel disease, a significant number of patients are now being medically managed. It's hard really to justify this in the current setting. So this is what this has led to, this development of complex and higher risk and indicated patients where we've shifted the syntax score towards the right, and now we're getting more and more complicated patients. And really there's a risk treatment paradox, because what's happened is we're ended up with more and more patients who are complicated in multiple areas, and as we've seen, their mortality is higher. This is how we divide CHIP into left main and multi-vessel disease, advanced CKD, mechanical circulatory support for shock and high-risk PCI, and chronic total occlusions. In this situation, it would be too much to go through everything. I'm going to focus on a specific interest of mine, which is advanced CKD. You can see clearly that CKD and contrast-induced nephropathy leads to a significant increase in mortality over 1 year in patients where there's CKD present previously, with up to 25% death. If you look at the Poseidon study by Somjit Brar, you see that there's a 7 times increase in major adverse events, with an increase in death, MI, and dialysis for patients who develop contrast nephropathy. And in fact, CKD leads to a reduction in the utilization of medical therapy that's appropriate for patients with multivessel disease and with poor ejection fractions, including statins, beta blockers, and ACE inhibitors, despite evidence to the contrary, which shows that these patients are the most likely to benefit. The options have been limited. This is the Mozart study, which was published in JACC Interventions, which actually showed that IVUS was one therapy which may be able to reduce your total amount of contrast utilization and therefore minimize your risk of CIN. But this is the first ever description of percutaneous coronary intervention without using any contrast. This is zero contrast PCI. This publication is in print at the European Heart Journal and represents a major shift in the way we treat these complex patients. This is 31 patients with a median creatinine of 4.2, glomerular filtration rate of 16, and zero contrast PCI was performed at least 1 week after minimal contrast angiography, where the total amount of contrast volume used could not be greater than the glomerular filtration rate. Zero contrast PCI was performed using IVUS with pre and post PCI measurements of fractional flow reserve and coronary flow reserve to confirm physiological improvements. And here, unfortunately, you can't see. This is a scatter plot showing improvement in FFR from red dot to blue dot, and this is improvement in coronary flow reserve from red dot to blue dot. No major adverse cardiovascular events, and preservation of renal function without the need for renal replacement therapy in all patients was confirmed. So how do you actually do this in real life? So here's a patient, 51-year-old male, former smoker, past medical history of hyperlipidemia, hypertension, and CKD stage 5 with a creatinine of 6.1. He has CCS class 2 to 3 angina. He's had a recent STEMI. 2 weeks ago prior to admission, he had a choking sensation with nausea and chest pain and has a positive troponin. He underwent a nuclear SPECT study which showed a large area of inferior and moderate area of anterolateral ischemia. He had a sum stress difference of 11, and the patient was referred to the CHIP service at SHA-MC for further management. Exam was really normal. The patient was on maximal medical therapy for angina, normal ventricular function. So when you perform minimal contrast angiography, no femoral arteriogram is performed. This is a micropuncture wire which is bent to make sure that you're across from the femoral head. Radial access is avoided in order to avoid looking for the ostium of the vessels, because of course the catheters were specifically designed for the femoral. Always pre-PCI left ventricular end diastolic pressure guides hydration. This is from the Poseidon study. I don't pre-hydrate the patients outside. They're hydrated according to the end diastolic pressure. Why? This data, unfortunately, we've lost some signal here, but the reason here is that the contrast volume to EGFR ratio was set at 1 because this is actually 1 here, and as you get to 1.5 and 2 and 3, there's a significant increase in your risk. So when you perform minimal contrast angiography, you just do 3 image acquisitions for the RCA and iliocranial, for the left coronary artery, an AP cranial, and an AP caudal. In situations where the GFR is so low that you can't actually perform a completed angiogram, we actually recommend the use of 20% dextrose because it has the same viscosity as, or similar viscosity to contrast, and that is what actually allows you to perform angiography. If need for PCI is unclear, you can easily perform FFR without contrast. I should mention that the FFR wires that are coming through are very, very good. There's now a pressure catheter, which I'm going to show you soon. In fact, Boston Scientific now has a wire that's made by Asahi that is considered to be similar to a workhorse, and the new next generation St. Jude wire is also very high quality. So again, post-angiography, another EDP should be performed because this is really what guides your hydration. Now, when the patient returns for their PCI, 1 week later, a limited echocardiogram is actually performed to rule out a pre-existing effusion, and this actually showed a normal ventricular function. Again, no femoral arteriogram is performed, and when they come back, a pre-PCI LV EDP guides the hydration. You start the case by actually advancing a preformed loop into anywhere into the coronary artery that it will go. Okay, you've engaged your coronary, the loop is safe, and allows you to advance into the coronary. Following your first advancement, standard workhorse wires are used, and you're starting to create a metallic silhouette of the heart. Here you can see a screen is masked for you guidance, and I'm wiring the LAD here, which goes into the diagonal and then quite quickly goes into the left anterior descending distally. And then the screen is masked for your other vessel, and here we're wiring the ramus vessel, which is the culprit lesion, and now we've ended up with a metallic silhouette of the heart in multiple views, which is going to guide us as to how we're going to perform our PCI with fiduciary markers. Predilation with a 2.0 balloon was used to facilitate passage of the IVUS in this case, and then actually the IVUS would not pass, so we use a 2.5 by 15 compliant balloon to allow the IVUS to pass. Once the IVUS passes, The distal reference is marked by cine angiogram, which you can see this black dot making note its acquaintance to the guide and the other wires. You have to have the patients well sedated so they don't move. Here you can see the distal reference is 2.7 by 2.5, and the proximal reference is 2.7 by 2.83, again marked by cine angiography. IVUS guidance allows us to determine the distal reference, the proximal reference. It allows very clearly, as you can see here, to determine the total length and the plaque morphology. You can see areas with dense calcification, fibrous plaque, and in this case, osteal disease, which makes the procedure much more complicated. So again, the distal reference marked by the prior cine angiogram, and then a 2.5 by 34 millimeter drug-eluting stent was placed exactly how it was told by the IVUS. And so again, you can see where the marker is, where the guide is, and where the stent is placed within great proximity. IVUS is then performed following the stent deployment, looking at the distal reference and the proximal reference, but here the minimal stent area is significantly underexpanded, and this allows focused post-dilation to the areas that are underexpanded, staying away from the edges of the stent. So a 2.75 by 15 non-compliant was used proximally, and a 2.5 by 15 millimeter balloon, a non-compliant balloon, used distally. And following this, repeat intravascular ultrasound is performed, and here you can actually see that the stent is starting to look much better well expanded, even though there's dense 360 degrees of calcification. Here you can see the distal reference area, the minimal stent area, and the proximal reference area, and by music criteria, we achieved 89% expansion. So now, in order to complete our case, we actually need to perform IVUS of the other vessels because we've stented the ostium. And one of the things that you will note in this situation is that the LAD itself is rather free of disease, and as we come into the left main, you can see only just a few struts. So here's the left main, and with osteal stenting of the ramus, all guided by imaging, we've pretty much nailed the ostium. We do the same thing from the circumflex, again to allow to make sure that there's not been significant osteal plaque shift. And what you'll note, again, is very few struts in the left main. Here's the left main, and here's the ramus intermedius here. Finally, once you've performed that part of the procedure, you assess your stent and wire assessment to make sure that the wires have not moved distally. This is an important part of the procedure. Again, workhorse wires should be used in most situations. A post-PCI physiological assessment is performed following the procedure. The way this is done by actually guiding the pressure catheter, which is made by assist. So this is basically a fine cross which has a FFR transducer on its tip. The advantage of this is that it's rapid exchange and you do not need to replace or move the wire. You simply guide the FFR catheter on top of the wire, measure FFR, and in this case the FFR has gone to normal. But as you recall, this patient needed multi-vessel revascularization. This is complete revascularization. This is a Corsair 130 centimeters with a pilot 50, which is guided into the distal vessel. Here's the uploaded angiogram that was taken 1 week before. The Corsair is then advanced through the lesion, and the pilot 50 was exchanged for a 300 centimeter BMW. And predilation was performed with a 2.0 by 15 compliant balloon, again to facilitate IVUS. The distal reference was marked with a cine flag by IVUS in this situation, and again, this allows us to perform targeted predilation and then targeted stent placement. So again, using these fiduciary markers, asking the patient not to move and keeping them well sedated is very important. The lesion length is guided by the IVUS, and dry cine was used for overlap, which was only 2 millimeters, and then the proximal stent was placed. IVUS was optimized the procedure, so afterwards we repeated intravascular ultrasound to see areas that were underexpanded, and we used the stent balloon actually distally at 10 atmospheres and a 3.5 by 20 proximally at 20 atmospheres. And then finally, your final IVUS confirms whether or not you've achieved adequate stent expansion, and your pressure catheter, again placed into the distal RCA, now shows a normal FFR. For the completion of the PCI procedure, all patients should get the LV-EDP reassessed. We have some very interesting data coming out to show that we're probably doing this wrong by measuring the EDP only at the beginning of the case. There's actually significant blood loss during the case, and in many cases the LV-EDP is significantly decreased following the procedure, and therefore we're underhydrating our patients, specifically with those with CKD. A post-procedure transthoracic echocardiogram should be performed in the cath lab to ensure that you haven't had a perforation. And if post-procedure the patient has symptoms, EKG changes, and if the coronary flow reserve does not improve to greater than 1.8, if there's no improvement in FFR, or if there's a new effusion, those patients should have limited angiography. So in this patient, the patient was now completely revascularized and angina-free. The post-PCI creatinine was 5.7 milligrams per deciliter and stable at 5.9 milligrams per deciliter at 6 months of follow-up. So in conclusion, patients with advanced CKD who require revascularization, PCI may safely be performed without contrast using IVUS and physiological guidance with high procedural success and without complications. This is the publication that's in European Heart Journal, where we used high-definition intravascular ultrasound with echo, which actually guided a different procedure. But this is not limited to high-definition IVUS. In fact, the ability to co-register and perform measurements, here this is OCT guided with saline, no contrast used. So there's some few tricks that you can do to get adequate clearance with saline, but this makes the procedure very, very easy because the distal reference is marked by co-registration. This is not limited to very simple lesions. This is a rota PCI without contrast. This is a 1.5 millimeter burr followed by a 275 by 38 drug-eluting stent placement and the previously placed minimal contrast angiography. The post-PCI FFR in this case was 0.90, completely relieved ischemia, and a coronary flow reserve of 3.0, which confirms that there's no slow flow in particular and an improved prognosis. So I'll leave you with the Iron Shield. This is some of my colleagues who work at Columbia University Medical Center, which is has been a fantastic place for me to begin my career. Thank you very much.